Welcome, everyone. My name's Nancy Reynolds. I'm a professor and associate dean of global affairs at the Johns Hopkins School of Nursing. I'm co-chair of the CUGH Workforce Capacity Building Task Force, and I'm vice chair of the CUGH board. It's really my pleasure to welcome you to the CUGH 2023 virtual satellite session, Building Sustainable Health Workforce Capacity. I'm really looking forward to the comments from our really excellent panel of speakers today, and hopefully we'll get input from our participants as well. This session is organized by the CUGH Workforce Capacity Building Subcommittee, and I would just like to take a few moments to give special thanks for sponsorship of this session by the Robert J. Harvey Institute for Global Health at Northwestern School of Medicine, the University of Illinois at Chicago Center for Global Health College of Medicine, the UTMB Health, the University of Texas Medical Branch, the Office of Global Health at the University of Maryland School of Nursing, and the Johns Hopkins School of Nursing Center for Global Initiatives. Rising disease burden and health inequities remain crucial global health concerns, and they really highlight the need for health system strengthening with an ample and appropriately prepared health workforce. Traditional higher education models have really not been sufficient to adequately support health workforce challenges and build capacity. So the purpose of this session is to describe the goals, lessons learned, and opportunities for new innovative approaches for building health workforce capacity, and to highlight the role of universities and university-based models to support health workforce development, with particular emphasis on models for supporting health workforce development in low to middle income countries, where the health workforce shortfall is particularly acute. So our session today is going to be structured such that we are first going to hear about WHO Global Strategy on Human Resources for Health and the Workforce 2030. And then we will have a little time for discussion. We'll follow this by a discussion about common challenges and the need for new approaches, getting perspectives from a few different regions and from a broad university-based perspective. And then we'll be able to highlight some examples from CUGH workforce subcommittee members and some of the different types of projects that they're currently involved in. So I would now like to take a moment to introduce my co-moderator, Matt Daskal, who is Associate Professor of Internal Medicine at the University of Texas Medical Branch and the Director of Academic Partnerships for UTMB's Center for Global and Community Health. So Matt, please.
Thanks so much, Nancy, and thanks to everybody for taking time out of your day to come to this workshop. I think, especially as we kind of lurch through these, phases of confluent pandemics, this is an extremely important time for academic engagement in global health. And so I'm grateful to my colleagues in the workforce subcommittee of the CUGH for putting this session together and for taking their time to share their knowledge, and of course for our main speaker for taking time out of his day from WHO to come and share knowledge. I'm not a very good disciplinarian, for those who know me, but I'm going to do my very best to help moderate the discussion a little bit. Just some ground rules, just to please keep your screen off and your sound off while the speakers are speaking. We've all been on Zoom, I think, for a few years now, so we're all pros, but every once in a while that mute button forgets to get initiated. And so we hear background noise. We will do our best to mute people if we see sound coming through, but please try to mind the mute button and to keep your sound off while speakers are speaking. We're also going to provide time for discussion we're going to have time for comments and questions after each session, but if something comes to mind, please do ask questions and make comments in a chat box throughout the session. We do have some help moderating that, and can queue up questions or comments that may come up through the presentations. If you do want to say something, we would just ask that you use the raise hand feature, and do that at the end of the sessions. And we will answer, we will take as many as comments or questions as we can in the order that they appear with the hand up. So I think those are the main ground rules that I have, and I'm going to just bounce it back to Nancy to continue carrying us forward.
Great, thanks so much. And now it's my real pleasure to introduce Dr. Jim Campbell. He is the Director of Health Workforce at the World Health Organization, and he joins us having just finished the WHO 5th Global Forum on Human Resources for Health. So we're going to get some very fresh perspectives from that meeting and discussion. So Jim, thank you.
Thank you very much, Nancy and Matt, and good afternoon, good morning, good evening on this side of the water to everybody in the virtual audience and those there. A pleasure to join you. And exactly, Nancy, we've just finished 4 days of the 5th Global Forum on Human Resources for Health, and really an opportunity to come back to one of the key themes of this discussion is around some of these contemporary issues, the contemporary challenges, and some of the outcomes that ministers and partners and delegates have reached a consensus on here. What might that mean for the consortium of universities in global health, for all partnership around some of the second half of the Sustainable Development Goals? I'm going to quickly just share some slides with you at the same time. If you can just confirm you're able to see those okay?
Yes, sir. They look great.
Absolutely. Thank you. So just to the key elements here in terms of where we are. The global strategy on human resources for health that we published in 2016, covering the SDG period, really looking at the opportunity to recognize the complexity of challenges around the world: climate change, infectious disease outbreak, urbanization, and many others accordingly. And we set out, after a 2-year period of consultation, a strategy which was in 4 core objectives. One, to really protect the existing workforce and make sure that it was enabled to deliver care and services on an equitable basis to populations. 2, to anticipate future needs and invest in the education and creation of jobs to drive that. 3, to support those institutions, education institutions, government institutions that would be responsible at the national level to carry that work forward. And 4, to support that with the data, the evidence, and the dialogue to really inform a decision-making that would be efficient and effective. We're now coming up to the halfway point of the SDGs, the 30th of June, 1st of July, 7.5 years in, a moment of reflection. We're also coming out of 3 years of the global pandemic. But earlier, before COVID, we were seeing public health emergencies of international concern impacting health systems across the globe, whether that was the Zika virus, Ebola virus, and then all the climate-related and conflict-related disasters that were coming through. So we're asking ourselves, what have we learned from the first 7.5 years? What have we learned from these public health emergencies of international concern, and how might that help us consider those actions? How can we learn from this historical period to inform the future actions going forward? And in September of this year, that debate will happen in the UN General Assembly. Next month here in Geneva at the World Health Assembly, the ministers of health will gather to reach their consensus and their content and evidence to go into the UN General Assembly, and then heads of state, ministries of foreign affairs, other parts of government will come to their deliberations. So what are the issues then around, in particular, the workforce challenges, the workforce context that we're seeing? In 2016, WHO described a potential 18 million shortage in the workforce in relation to the ambition of universal health coverage. At the halfway point, we have seen global progress, but that progress is not, it's inequitable, and it's different across regions. What we're seeing now, the education investments that have been going on for the last 10 years, 7.5 years of the SDGs, the last 3 to 4 years, starting to come to fruition. Greater number of education graduates in the supply, greater absorption into jobs. And so that 18 million figure coming down to 15 million prior to the pandemic and the data that was made available. And with it, if again, prior to the pandemic, on those trends, anticipating 10 million shortage by 2030. So you can see, for instance, in this slide, the Southeast Asia region, making substantive progress overall in terms of its numbers, but less progress that we're seeing in the Africa region, the Eastern Mediterranean region, not necessarily because of underperformance. There is substantive progress, but also these figures reflect the challenges of a workforce that's got to respond to population growth at the same time. And so it's almost a race to stand still with the population that's growing in some of those environments. Then after the pandemic, what else are we seeing? There is a real contemporary issue on international migration and mobility. We saw countries around the world trying to surge their workforce capacity, trying to rapidly add the number of personnel available to continue to deliver services, to expand the capacity to respond in the acute sector and in the public health response, the tracing efforts, the vaccination efforts. Over 70 jurisdictions around the world introduced changes in their regulatory frameworks to make it easier to license and recruit personnel from other jurisdictions. And this then has translated into, from those OECD and high income countries where data is regularly reported, often every 3 months, every 12 months, we're starting to see the change in the numbers, a nearly 30% increase in the migration of physicians. And in a sample of 15 OECD countries, a rapid acceleration in the migration of nurses. As a result of that, the World Health Assembly last year agreed to reconvene an expert advisory group representative of member states, countries from all 6 WHO regions to look at the potential vulnerabilities from this increase in migration. And the figures are of concern. What we've seen is that in lower middle income countries, you've got a life expectancy which is 17 years less than in high-income countries, and even lower in some of those regional groupings. We're seeing that there is one health worker for every 70 inhabitants in high-income countries, but one health worker for 700 inhabitants in low and middle-income countries. So the expert advisory group, looking at these vulnerabilities, look at these movement patterns and trends with anecdotal evidence, media evidence, feedback from the countries themselves, as well as these more empirical data, recommended to the Director General that we add an additional 8 countries to the WHO Health Workforce Support and Safeguards list to ensure that there are the appropriate provisions to ensure protections and safeguards coming through, and discouraging active recruitment from those countries that are particularly vulnerable. In addition, a contemporary realization at this 3 years of COVID-19 that the public health workforce has been undervalued, less investment, less consideration of it, and that we needed to elevate the discussion around, the capacity in every country, in every national system, to deliver the essential public health functions, including the function of emergency preparedness and response. And in the G20, led by Italy, this was elevated as an action and a consensus amongst countries, which then triggered a whole expert consultation and partnership with the associations, the institutions, the schools of public health, as represented by their national bodies, their regional bodies, and their international bodies coming together. And we welcome also, thank you to the Consortium of Universities of Global Health, who've supported this and endorsed it and are now participating in its implementation, to really look at those personnel who perform the core public health capacity, those who have a role in one or more of the functions, and those other sectors and occupations that are also engaged. And all of this deliberation has fed into the 4 days of the Global Forum here. We've had over 4,000 virtual participants registered, over 70 hours of technical discussions, plenaries, parallel sessions, roundtable events, to really look at some of those challenges under this title of Protect, Invest Together. It really has been quite a whole new, the value of this virtual participate, record levels of numbers engaged accordingly. And one of the big questions, well, this 10 million shortage, where is it? What we do? One of the key lessons is that every country has some type of shortage. Those have got absolute greatest shortages, those with relative shortages in terms of what they need to accelerate in terms of today's capacity against those future predictions. Within different geographical groupings, if you look at the small island developing states, again, within that grouping, there are shortages. In the high income countries, there are shortages. In Europe, in the US. So everybody has those issues, which triggers discussion on the skill mix, the education, the retention, the attrition, the gender dynamics of this. Which takes us then to some of the outcomes and the conversation that we've got to see. The meeting reached, through its deliberations, started to reach consensus on a number of critical points. The success that we've seen in many countries around the world demonstrates that education can rapidly accelerate. It can, if we start to see production rates around a range between 8 to 12% of the active stock, it can achieve the doubling of the workforce in less than 10 years. And there are countries, low and middle income countries, that have achieved this and demonstrated it. And therefore, on that basis, with the political will and leadership, there's no reason why we can't continue to drive that work forward. And the cost of doing that is relatively against some of the GDP and against what we've seen invested for the pandemic as a result of the outbreak, that somewhere in between 0.3, 0.5 of GDP, we could invest in that education to double the workforce. But at the same time, we can't just increase graduates, we've also got to increase employment opportunities. The phenomena exist in lower middle income countries of unemployed health graduates at the same time as the population demand is there for additional health workers. And this is some of the challenges around the economic demand, the ability to pay wages. On migration and this rapid acceleration that we're seeing, an agreement that high income countries need to also invest in their education systems. They need to be having a domestic supply themselves, which would reduce a reliance on international medical graduates, international nursing graduates, pharmacists, dentists, all occupations, and that they should actively avoid recruitment from those 55 countries, and to strengthen the implementation of the WHO Code of Practice on the international recruitment. Against some of the measures around retention and attrition and the reality of the mental health illnesses, a real commitment to protect the existing workforce through decent working conditions so that the investment in that human capital is enabled, that it's enabled to focus on quality care, equitable care and the access, rather than having to contend with working conditions which are undermining performance, undermining productivity. And through all of this, to look at the policy dialogue, working together across sectors, using the data and evidence. And that's the sector. We had education ministers, we had the gender represented, social protection represented, finance, looking at this intersectorality accordingly. And so from these headlines, Nancy, Matt, what can universities be doing? The ambition is that we come together to help these countries get to the situation where there's enough investment to double the number of graduates, double the workforce. So that's investment in education, investment in jobs. That we also ensure that high-income OECD countries, where many of your universities are also based, get to less reliance on the workforce and putting in those national policies that do it. Looking at how we audit decent work, looking at how we support the evidence base for decent work conditions, the retention and therefore reducing attrition of the existing workforce. So huge opportunity for a partnership on the public health workforce, the workforce for primary healthcare, the workforce for universal health coverage, looking at this education employment nexus and the evidence base. So that's the 3 E's that I will leave with you: education, employment, and evidence. Nancy, back to you.
Wonderful. Thank you so much for that overview. And, all of these critical things we need to be achieving. Do you get the sense that there is the political will with so many competing demands?
Dr. Tedros has since been elected as the Director General, has continuously suggested that universal health coverage is a political choice, that preparedness, emergency preparedness and response is a political endeavor. We've had the International Parliamentary Union with us, the Secretary General Martin, really talking to us about we need parliamentarians to really, and civil society working together to make that a political reality. So we take the choice away. It's no longer a choice, it's a political must. Is there the political will? I think we're seeing that where there is political will, we can make substantive progress in a rapid time. Our job is to put the evidence for action into the hands of those parliamentarians and politicians.
And I guess another question that came to my mind listening to you speak, and I do see universities having such an important role in supporting this agenda. But I know WHO works with universities, I think largely through the WHO collaborating centers, and otherwise it's working pretty directly with governments. And I guess that's something that concerns me is oftentimes, so many universities were involved in kind of individual level efforts working with perhaps universities in other countries, but do we really have the impact that we could be having if we worked in a
It's a excellent observation, Nancy, in terms of, we've got to, resources will be scarce in the second half of the SDGs. The economic climate and the globally is going to be a real challenge. So we need to be efficient and effective. We've welcomed partnership with, I think, nearly 700 universities are collaborating centers with the World Health Organization. It's a long tradition of accordingly, but I could see huge potential for consortiums of universities really focusing on the next 7.5 years, the most critical challenges in global health, coming together to add greater effectiveness, to pool those resources, to pool the data, pool the evidence, because the behavioral change we need is the impact that we're looking for. It's not just knowledge. We want to have knowledge which helps that behavioral change in the policies and in the investment decisions.
Great, thank you. And Matt.
Thanks so much, Jim. That was really a great presentation. I know Dr. Martin has a question in the chat. I just had a quick one I wanted to get in there, and that was, I remember the 2006 World Health Report that really, I think, was one of the seminal reports that described the crisis of human resources for health. And I when I teach about HRH, I always show this really beautiful chart in there where there was an analysis of about 4 or 5 countries of kind of the root causes. What is it that is causing retention, or that is leading to exodus, and what is it that? So what are the push and pull factors, basically? And I appreciate, and I think it's really important to have the policy kind of, let's say, the stick of, hey, don't recruit people, from, don't to have these recruitment practices that are causing the brain drain. What do you think is a way forward on addressing some of the push and pull factors that are really the root causes for health worker migration around the world?
There's in every country, I think we've got to avoid too many generalizations. Exactly as you say, you've got to look at the particular context in that particular country to unpack. But there are a number of factors that tend to stand out on every occasion. We need to educate people for the domestic market and the needs of the population and the demands of the health system. We need to ensure that the competencies they graduate are specifically related to that. We need to distribute that workforce in an enabling environment. If we don't create employment opportunity, if we don't create career pathways, if we don't provide occupational health and safety, if we don't provide a decent living wage with regard to the national economy and maybe any regional economic body, we're increasingly seeing these regional economic areas with freedom of movement for tertiary specialists of any education professional. So you've got to look at the national labor market, the regional labor markets, and provide that decent wage to try and stem some of those push factors that are encouraging people to look for that. The pull factors, Clearly, high-income countries need to invest themselves. They cannot subsidize their health systems on the basis of graduates from low and middle income countries. But we don't want to stop migration. That education, specialization, that training partnership, it has value. It informs our health systems in the global north, that it helps support the learning and the exchange of ideas and cultures. So we don't want to prevent that, but we do want to make sure that it's a appropriate migration for the context and for the labor markets accordingly. There's many different issues, but the first big one, we've got to create decent work and decent jobs, and that would have an impact. It's if you're unemployed in a particular country anywhere in the world, with all the 3 years of a bachelor's specialization, 4 years with an advanced practice, 7 years as a physician, you will look for work. So let's make sure that we're creating that work. In terms of Keith's suggestion, in terms of that administrative, this is an element in any civil service and in academia. The high turnover of personnel you may often see in a civil service, the minister changes every year. You may see those the parliamentary process every 4 to 5 years there's change. So how do we make sure the investment decisions are translating into that? What was an objective in the strategy? Building national capacity in the education institutions and the administration. Data. How many health workers do you have? Where are they? What are they doing? Putting that into the public domain and using then education institutions to take that public data, that common public good, to help inform accountability, transparency, policy decisions, again, to be even more efficient, more effective. If we hide data, if we keep it to ourselves, it's that famous, data hugging disorder. If we hide it, we're not actually supporting global public health. So there are opportunities to do that. One of the other questions in the chat, what do funders need to do? We had a fantastic day, 4.5 hours of deliberations with partners from international financing institutions, global health initiatives, the private sector, philanthropic funds and governments and civil society and professional, exactly those issues. And how can we leverage the investment needed in education and jobs? How can we make that align our different resources to support the national public priority? How can we then sustain that resources for the longer term, and how can we make it more predictable? And I think there's some momentum here that we really would like to see, but it doesn't stop in one meeting. That same debate will continue at the World Health Assembly, and I'd ask the Consortium of Universities of Global Health continue to drive this agenda. We must, the conference Protect and Invest Together. The first thing we must do is protect the existing spending on health against economic challenges, protect that investment and grow it for the future.
Great. I see there's one other question here, Jim, in the chat box. Someone thanks you for your great talk and wondered about how much emphasis there's been on mental health workforce parity, which obviously we're aware. Just
Nancy, one of the things we very deliberately did as a decision in the preparation of the forum, the opening session featured the stories of 4 health workers from around the world talking about their lived experience during the pandemic and their lived experience in the professions that they occupy, emergency physicians, nurses, the experience that they were facing. And we heard some their testimonies, their voices on exactly those issues: the stress, the anxiety, the moral injury, the moral hazard, the burnout that they're experienced. So we gave those health workers a voice deliberately to say that we have to, that's one of the elements of decent work. We have to remove the stress, the factors of stress that we are placing upon today's workforce. We need more health workers for the future. And if they look at their, the people that are in there today and the levels of stress and anxiety, that's not an advert for the future workers that we need. So we must put that investment in there. It's the evidence is just we've never had this level of stress, anxiety, and burnout in the health and care workforce.
Thank you. And I think you touched on this a little bit earlier, but another question in here from someone who joined the WHO Global HRH Forum, and they said there were great ideas, but how do we ensure that governments really are committed to protecting and investing in health workforce?
We heard the ministers who were present. Like I said, we had education, finance, gender, health, social protection, the different sectors represented. They took time out of their calendar to come here and actually deliberately speak to this agenda. They're committed, but I think the ministers of health all around the world and other sectors are aware of the challenge. What we've got to do is now really mobilize support for them to ensure that we have the sustainable, predictable investment to create jobs, to ensure that people are paid a decent and fair wage. We've seen record numbers of strikes and protests around the world. Over 160 countries have had an experience in the last 3 years of some form of labor protest by their health and care workers. Again, it's the 75th birthday of WHO tomorrow. Never in our records have we seen this level of industrial dispute in our sector. So all the evidence is there. I think there's some clear political leadership to make a difference. Our job is to come together and help them get us into those action.
Excellent.
That was great. Thank you so much, Jim. That was just a phenomenal presentation, and thank you for answering those questions. Nancy, do we have time for one more? Or do you want to?
Is there one more question? Yeah. Okay.
Yeah.
One more.
Like,
Let's take one more question, and then we'll have to move on.
Yeah, it looks like Corinne had a question about how we're calculating the numbers within the WHO for the global gap. If there is unprecedented burnout and need post-COVID, how does that square with the stated declining gap in the health workforce? And if it was based on pre-COVID data, then will they soon be updated?
So thanks, Corinne. The tough one is the last one, yeah. So the numbers we're using, we discussed this empirical evidence base to enable that policy dialogue, and therefore the policy decision investment comes with it. Over 180 member states around the world are now reporting annually their workforce information through the national health workforce accounts, and that's a global public good. Please, go online, national health workforce accounts, search for it, use it in your evidence, use it in your policy dialogue. That data submitted and updated annually. So we're seeing obviously there's either a year or 2 year data lag, and depending on the administrative capacity of countries to be able to collect and publish that data and then share it with the WHO. So it is fairly contemporary on the numbers. And what we're seeing is the Universal Health Coverage Index is the measure of performance of the health system and the workforce and the correlations with this. So it's a tried and tested, and Matt, as you said, the 2006 World Health Report, similar methodology, but updated with much better data, much better methodology coming through that. On the unprecedented burnout, we did a review of reviews published in November of last year, which took all the systematic reviews that have been published, and we did through that process, we looked at the incidents and we ended up with these ranges: almost 1/3 with stress and anxiety, almost half with burnout, and in some occupations, in some settings, in some countries, it's higher. So this is just the range across all that. How might it translate into the thing? And I think this is a very important point to look at. There is this discussion from high-income countries, OECD countries, about a great resignation from the workforce. Different jobs, different sectors and everything else, but also impacting health. However, you need to look to the latest data from those countries who produce quarterly statistics, those who produce biannual and annual statistics. And when we look at those high-income countries, the 10 to 12 that are producing this on a regular basis, the health and care sector is still growing. It is just that people are starting to move within it. They're coming out of highly stressful, 60 hours a week jobs and saying enough's enough. I'm gonna get better balance, but they're still in the health and care economy often, but they're in a different role. And it may be in the private sector, or it may have gone back into the public sector with an academic mix. The numbers are still there. So overall, the head count, but we need to go along and look at part-time. But then it is not the same when you look at a lower, those choices at this moment seem to be confined to very wealthy settings for people of a certain age group who potentially have got more choice. It's not the same when you look at people on minimum wage. It's not the same in the US, where you're only getting $15 an hour and you need that wage to be able to sustain your livelihood. You don't have that choice to resign and go and seek other work. And it's not the same when you look at lower middle income countries. So we really need to be in our evidence, as I told you, education, employment evidence. In that evidence, please go beyond advocacy and publicity and ask the question, is that real? Does it apply? And can we therefore act in the national context to make it real?
Jim, thank you so much. Really appreciate your thoughts there. I think as folks that are representing academic institutions and engaged, that's one of the main things we do is healthcare workforce training. So it sounds like you have a lot of allies here, and certainly we appreciate all the time you've taken to answer questions and share your insights and thoughts. And thanks to all who made comments and who had questions in the chat. And I'm going to hand it back over to you, Nancy, to take us forward.
Great. And yeah, thanks again, Jim, so much. I know this has been a demanding week for you, so for you taking time out. And I know you're stimulating a lot of thought on our part about how we may help move this agenda forward or support it as we can. And Keith reminds us in the chat box that we've got a network of 34,000 persons, as well as working with AfriHealth, other organizations. And I certainly think there's going to be an opportunity for us to try to act on some of these important agenda items. So again, thank you very much.
Thank you very much, Nancy, Matt, and Keith, and good luck with the rest of the event. Wish you well.
Thank you.
Thank you, Jim, very much. Thank you.
Hey, so that was really wonderful, stimulating data, giving us a lot to think about. And we're going to move on to the next part of our session, where we really want to start to think about some of the, common challenges, as well as perhaps challenges that are unique in different regional settings, and really be thinking about, the need for new approaches. And it's my real pleasure to introduce Dr. James Fitzgerald. He is the Director of Health Systems and Services at the Pan American Health Organization, the regional office of WHO in the Americas. And he's going to share perspectives from the PAHO region and information about a new initiative that addresses some of this agenda we've just been talking about, called the America Health Corps, which aims to facilitate the training of 500,000 public health professionals. And this is particularly pertinent, as Jim Campbell was just mentioning, that they sort of recognize that this is an area that has not really received enough attention. So let's see. Oh, there you are. Great. I'll turn it over to you. Thank you so much for being with us.
Thanks so much, Nancy. Very good afternoon to you and to everyone. So yeah, thanks for that introduction. We've put together a short presentation for you today that really does outline a little bit of where this initiative is and where this initiative is actually going. So if you could just confirm that you can see the presentation.
Yes.
Very good.
Right.
Okay, that's great. Yeah, so very much building on what Jim has been talking about, I wanted to present to you today three, I suppose, big picture items in terms of the context of the health workforce in the Americas. What are the main challenges, particularly looking at one of our regions, which is the Caribbean region. Then looking at the conceptual framework and key pillars of the Americas Health Core Initiative, which was launched last year following the Summit of the Americas, and then presenting for you some of our next steps and how we're approaching this whole issue. In 2017, 2018, there was considerable discussion around the issue of human resource for health within the context of universal health coverage in the Americas. The region had adopted a framework resolution around universal access to health and universal health coverage that has really guided, I think, much of our health system strengthening, health sector reform processes in the Americas. That was in 2014, as I said. And then it became very clear that as we began to implement that mandate with countries in the Americas, there was a key piece that was really missing. It was around the health workforce. So we went back to our governing bodies, went back to the countries and developed a new strategy, which was essentially titled Human Resources for Universal Health at that time. And that strategy really had three main tenets to it. First of all, the governance and intersectoral policy side with issues around health workforce policies, investments, strategic planning processes. Secondly, the issue of training health professionals based on the needs of health systems. And so really shifting and scaling capacity and training for primary health care, looking at the linkages between education and health workforce, across all spectrums and competencies, and then really looking at interprofessional health teams and how they're deployed and operational. And then there was a third area that really looked at that interprofessional element to ensure that we have people, the people that we need where they're needed. As Jim very well mentioned, one of the enormous challenges, irrespective of the level of income of the country, that everyone is facing is essentially the availability of qualified workforce, particularly in peri-urban, poorer areas, but also in rural areas. And this is irrespective of whether we're talking about the United States or we're talking about Brazil or Chile. So this is a major issue across the region. As we then moved into the pandemic, we really began to realize that the capacity of the health systems within the Americas was fundamentally dependent on the investments that had been made prior to the pandemic. Some of the data that we looked at this point in time was to really see how levels of public expenditure were significantly lower in Latin America and the Caribbean compared to the benchmark that was set for the region at 6% of public investment in health. But not just looking at investments in health, but also the out-of-pocket expenditures, which the target set by the region was 20%. And so that we see in this graph here that essentially only 3 countries, this is for Latin America and the Caribbean, Canada, the United States also fall within this quadrant. But essentially 3 countries from Latin America and the Caribbean fell essentially within this target quadrant of health financing at 6% of public expenditure, with lower than 20%. And we can see that the OECD is essentially there, whereas much of the remaining countries in the Americas have very low levels of public expenditure and very high corresponding levels of total health expenditure, which really speaks to the issue of high risk of catastrophic expenditures and impoverishments, not to mention the lack of access and coverage of healthcare systems. Associated with this has been the lack of investment in the health workforce. The data that we've collected based on WHO data and work with ECLAC in Chile really kind of can highlight how the previous context of health financing and the lack of political prioritization of strengthening and expanding health systems in the Americas has really resulted in a overall low numbers of health workforce in the Americas. And this data presents for you some information with regard to the availability of physicians per 10,000 population, comparing Latin America and the Caribbean with OECDs. Of course, we know this is exacerbated depending on geographical location and also the levels of, I suppose, of wealth distribution within that geographical location. So there are fundamental issues here associated with not just the health workforce issues per se, but the planning of the health workforce, depending on the overall structured planning of the health sector in itself to expand primary healthcare and the development of integrated health service delivery. I was listening to your comments and questions on the issues around quantification, and we face a similar challenge in the region. Depending on the methodologies that we look at or apply, we really see that there are significant shortfalls in the absolute number of health workers that are required. We estimate between 600,000 and 1.2 million, depending on the methodology. Irrespective, it's an enormous shortfall. And we can see that it occurs across, we've just selected four categories of health professional here, but it really is quite notable in the area of physicians, primary care physicians, dentistry and pharmaceutical, but with nurses and midwives, although really being noted as one of the key areas for shortage. And here I want to bring in the discussion around the Caribbean, because what we've seen in the Caribbean prior to the pandemic was a continuous outflow of health workers, particularly specialized nurses, but nurses of all types, out of the Caribbean into the US, into Canada, into Europe, and particularly the UK, with really ministries of health, the health sector, the labor sector struggling to keep up in the production of and generation of a health workforce that can actually meet needs. We've seen services actually shut down in some Caribbean countries because of the lack of availability or because of the mobility of specialized nurses from the Caribbean. We've seen this continue to flow, particularly we note that there has been an uptick since Brexit because of the particular, I suppose, focus and lack of mobilities or challenges of mobility within Europe. Therefore resulting potentially in extended recruitment of health workers from the Caribbean, but also because of the enormous demands that have been generated now within the US system and within Canada, whereby they can access well-qualified English-speaking health workers from a region such as the Caribbean. We are very concerned about this, and this is really a major priority for the organization moving forward in addressing this issue, particularly within the Caribbean. So, you know, I did have a couple of slides here to present the context of health workforce in the pandemic, but I think Jim has really spoken to that issue, so I'm not going to go into any of the details of what happened in the Americas. Just to say that in the Americas, we had the highest number of infections per WHO region, the highest level of mortality, and this really speaks to the issues around the political engagement of some countries to really address and tackle head-on the COVID-19 pandemic, but also the insufficiencies, the deficiencies, the segmentation, the lack of financing, the lack of health workforce that was available to actually tackle COVID-19 in the region. It's as a consequence of this that at the Americas, the 9th Summit of the Americas, a process by which the heads of state from the region of the Americas convene every 2 to 3 years, this time hosted by the US government, that President Biden announced the establishment of what is being called the America's Health Corps. And this is a broad initiative, a joint initiative with the Pan American Health Organization to really scale capacity in the production, generation, and training of health workers, to look at issues around access and availability, quality, and then to begin to look at the overarching determinants in the production of health workers for the Americas. It was somewhat simplified into an initiative whereby commitments were made to train 500,000 public health, health science, and medical professionals throughout the region over 5 years. The overall concept note that we have developed with the United States and which has been shared with our member states really speaks to the issue of the generation and capacity building at the national level based on the gaps that are identified within countries to really rapidly recuperate the lost public health gains we've seen, be it in maternal mortality or immunization coverage levels or an NCD or foregone care, or the enormous waiting list that we're seeing across the region of the Americas for healthcare, to recuperate those lost public health gains, to expand primary healthcare, but at the same time, really very much focusing on the issue of health security within the overall broad context of universal access to health and universal health coverage. So proposals are being developed now in terms of governance and structure and operationalization, and we're now looking at mechanisms for financing the initiative jointly with the US, but with other partners, of course, with WHO and the development banks in the region. There are 5 action pillars that have been identified for the Americas Health Corps. The first really looks at the issue of access and availability of qualified health workers, bringing this down to the national level, looking at the capacity of education systems to generate the health workers that are required, that are needed both in the short, mid, and long term, looking at the labor sector analysis and bringing this all together so that ministers of health, ministers of labor, education can really jointly work around a coherent plan for the future based on the model of care, based on primary health care within the context of that country. The second area really speaks to strengthening the virtual school in public health in the Americas. As you know, PAHO has the PAHO Virtual Campus. This is an initiative that was launched in 2014 to begin to provide education through a virtual platform directly to health workers. And whereas the campus grew steadily from the period of 2014 to the beginning of the pandemic, what we really witnessed at the beginning of the pandemic was an exponential growth in uptake in training and health workers actively engaging with the campus to seek knowledge, state-of-the-art knowledge regarding basic issues such as the donning of PPEs to more complex triage of COVID-19 and the complex management of patients in UCIs, in the ICUs, and everything from the reorganization, the surge capacity of health systems, right through to laboratory surveillance and genomic surveillance. And so through the campus, we organized and delivered jointly with WHO over 26 courses that were delivered to more than 1.2 million health workers in situ, in places where they are working. And we do feel that this instrument has shown itself to be extremely potent as a means to leverage state-of-the-art knowledge for health workers where they're working. And so the idea here through the Americas Health Corps is to continue with the development of the PAHO Virtual Campus. At this point in time, we have 2.2 million health workers registered in the PAHO Virtual Campus. And we are moving towards a process now by which we leverage the campus to address the principal and core mandates of the organization, and in particularly looking at learning pathways for health workers around specific health systems issues and disease control and management issues. So that's the PAHO Virtual Campus. In addition, we're also looking at the issue of leadership. I think we can all recognize that one of the principal determinants of success for a country during the pandemic was in fact the executive leadership, the intersectoral coordination and the management of that, and the overall governance and stewardship of processes at the national level to be able to guide, adapt, surge and respond, building that level of resiliency within the health system. And this applies to health security issues, but it also applies more so to health sector transformation. Many countries have the greatest plans and ideas in terms of health sector transformation, but unfortunately do not have the capacities in terms of change management. Many leaders do not have those necessary competencies to guide countries through a health sector transformation process, taking on board the complexity of some of the issues and the interested parties in order to achieve that overall goal. And so through the Americas Health Corps, we're also aiming to build a future leadership in health governance and public administration progress, public health administration course, whereby we convene the health leaders in the Americas and look at issues around health security, health systems transformation, health sector reform processes, obviously working in alignment with current mandates of the organization. The final two action pillars really speak to, I suppose, enabling factors that are required for us to be able to report success. The first is around the issue of the Americas Consortium of Academic Centers in Health Sciences and Public Health. And this is an initiative that we're looking at to bring together academic centers and universities, including the Institutes of Public Health around the Americas, based on gaps analysis that countries will define in terms of capacity requirements, and so that we can leverage their capacity in addressing those gaps. We will also be looking at through this consortium one major challenge that the region faces, and I think this is a challenge globally, which is the regulation of education, process for accreditation and certification of continuing education. So these are some of the really important challenges that really impact quality of care, hinder mobility, and really hinder many countries in scaling capacity of the health system. And finally, at the specific request of the United States, we also include a private sector element to this initiative, whereby we look at the role of the private sector in health workforce issues, not only from the educational perspective, but also in terms of the multiple digital platforms, either for telehealth delivery, digital transformation, digital education, that we can actually leverage for continued support of the health workforce. So I will essentially stop here. I have a lot more detail on this, but I don't want to overextend. I think really what I'd like to hear is comments and questions from you. In terms of next steps, we are engaging at this point in time the US government, funding entities such as the Pandemic Fund, the World Bank, the IDB, our colleagues in Jim and colleagues in Geneva around the initial funding that is required for this initiative. It is a major initiative, and as such, we are really looking to leverage major financing for it. But as of yet, we have not been able to consolidate that financing from the US government as they begin to identify where they can source the funding within their national budget. But notwithstanding, there are interesting proposals in development through the Pandemic Fund, and jointly with the IDB and the World Bank, this initiative is moving forward. This initiative will also be brought to our PAHO governing bodies, but more broadly from a broader perspective in terms of the Workforce 2030 in the Americas, whereby the Americas Health Corps will be one of the, I suppose, principal pillars of action for the region. This will move forward to our executive committee in June, and thereafter to our full PAHO Directing Council for consideration by all countries this year. So these are exciting times. There's an enormous demand in countries for technical support in this area. And that demand is essentially being driven by the substantive health sector transformation processes that countries are now undertaking, realizing that their health systems were not fit for purpose to be able to deal effectively with the COVID-19 pandemic. And health workforce is just one of the critical levers that needs to be addressed within that context by countries. So Nancy, I will stop there and I'll pass back to you.
Thanks so much. Yeah, thanks so much, James. This was really, really awesome. Wow, the America's Health Initiative, the America's Health Corps sounds just like a really amazing opportunity for engagement from the CUGH members, but also a number of the academic health science centers that engage in global health. I think we can probably take maybe one or two questions before we move on to the next speaker. So if anybody has anything, they can either raise hand or put it in the chat. And if there's nothing, then we will go forward on our next presentation.
No, really. I mean, I just want to say I'm so impressed with that initiative, especially in the context of just having heard all these kind of agenda items from, WHO's discussion this week, how this is such a broad perspective. I really, it is so ambitious. Are other regions or any other regions doing something quite of this scope? Because I'm not familiar with them, but.
I believe that the African Union is actually developing something quite similar also with the support of the US government, and particularly with the CDC, with CDC Africa. I do believe there is a major health workforce initiative. And these are being rolled in essentially into the global health workforce initiative that I'm sure Jim spoke about, which is being championed by Spain, but in particular the United States government, as a means to make sure that we're all a little bit better prepared for any future international public health emergency.
Yeah, and certainly, you know, you just sort of listen to the global situation. There are just so many gaps that are so profound. But this seems to have great potential to really have a lot of impact to making a difference.
That's right, Nancy, and we really feel that it is a great opportunity. Also for, you know, I think there's a great expectation also from Latin American countries through the summit process to see how the US can also reposition itself in terms of global public health and through an initiative such as this. So the US government has been really out at the forefront of this with the Secretary of State visiting countries and talking about it as a presidential initiative. And so we are excited, and we just really look forward now to, we feel that we have the pieces in place, and we're really looking forward as we almost arrive at a 1-year anniversary of the summit to really scaling implementation of this initiative.
Wonderful. And I see that Keith Marthan has placed in the chat box that CUGH has a capacity building platform that we're actually going to be talking about later in this session that links trainers with curriculum and training needs. So there may be some opportunity for some synergies here between what we have to offer in that regard. So thank you so much. And I think we'll move on to our next speaker, and then hopefully there might be a little bit more time for discussion at the end. So now it's my great pleasure to introduce Dr. Elsie Kilowawade, and she is the president of AfriHealth, and this is an interdisciplinary health professional group that seeks to work with ministries of health, training institutions, and other stakeholders to improve the quality of healthcare in Africa through research, education, and capacity building. She also serves as the Director of Health Workforce and Development at the African Center for Global Health and Social Transformation. So Elsie, I welcome you to take the floor. Hopefully she's here still.
I'm here, sorry.
Great. Okay.
Thank you, Nancy, for that introduction. Let me just share my slides.
We could see them
Just
for
give
a
me a
minute.
minute.
We could see them for a minute and then they disappeared.
Okay. Can you see them now?
No.
Oh. Just a minute, sorry.
Okay, sure. There, yeah, there it is.
Okay, thank you, and sorry for that delay. So I'm going to talk about building sustainable health workforce capacity, and I'll tell you a story about AfriHealth. But before I go into that, I would like to tell you what AfriHealth is, what we do, and then tell you about the work that we've done on strengthening interprofessional education for HIV, which in short we call STRIPE HIV. And this work was done between AfriHealth and the University of California, San Francisco. So what is AfriHealth? AfriHealth stands for the African Forum for Research and Education in Health. And it was established in 2016. It's an interprofessional Pan-African network. We represent health professionals and institutions from all over Africa, and we have some international members as well with a vast experience depending on where they work. And this initiative came out of the Medical Education Partnership Initiative and Nursing Education Partnership Initiative. And these were PEPFAR grants to countries in sub-Saharan Africa that were aimed at improving health professions education. And as the projects were coming to an end, we really thought it was important for us to sustain the gains. And that's how AfriHealth was birthed. So we work to achieve excellence in health professions education, research, and service delivery, and aiming at influencing a new interprofessional standard that would lead to sustainable and continuous quality improvement for the African population. We are a leader and convener for scaling up South-to-South networks and collaboration. And all this is aimed at addressing the daunting health workforce challenges that you've heard about from the previous speakers that are actually global challenges. But as we saw from what Jim Campbell showed, is even more daunting in our region. How do we address the health professions education so that we produce competent health workers that have a good skills mix that can be retained to work in areas where they are most needed? So the challenges are many, but we try to address this through innovative interprofessional education and research. And just to show you where we are in Africa, right now we are in those countries in orange, and our aim is to reach the whole of the continent by the end of this year. So we have over 700 members and over 70 institutions. And our activities range from doing research on locally relevant issues, on capacity building, as I'm going to show you one of the examples of the projects that we have undertaken. We do interprofessional student exchange, and this has been a successful South-to-South collaboration. We do webinars, and during COVID-19, this came in very handy because this was a new entity, and because of the lockdowns, everybody locked up in their houses. We needed to really reach the people and train them, and we used webinars to a great extent to do this. And we have an annual symposium, and this year it will be in Maputo, Mozambique. Every year we try to take it to a different region and a different country, and I would like to invite you to it. I'll show you a poster of that later. We have technical working groups. We've formed communities of practice, and we really work through partnerships like partnering with the CUGH. CUGH has been we have had a partnership ever since we started. We are a young organization, and we've worked very well with the CUGH, and Keith Martin has been very helpful in helping us establish our organization. So we have a strong collaboration with CUGH. So we really aim towards a responsive health workforce, providing relevant, high quality, evidence-based healthcare in Africa. This is really important to us. So I'll just give you an example of one of the projects that we have conducted, and we named it Strengthening Interprofessional Education for HIV. We began with HIV, but then later on COVID happened, so we added on COVID in Africa. And there's a big group that has been working with us on this project. Some of the names are highlighted there. So this is a partnership between AfriHealth and the University of California, San Francisco. and is aimed at capacity building in the region. And we use an interprofessional education and practice approach, aiming at the pre-service and immediate in-service health workers. That is people that are just about to complete or are doing their internship, that have just completed, or postgraduates that have just completed their postgraduate training. And we aim at service delivery, giving them examples, highest quality, collaborative, team-based, evidence-based care. And the aim is trying to link health professions education to clinical practice or the health system, because many times we work in silos. And in Africa, you find that in many places, health professions education is under ministries of health, and then the health system is under Ministry health professions education is under Ministry of Education, while clinical practice is under Ministry of Health. And many times they are not even talking to each other. So we want to bridge that gap through partnerships, creating communities of practice, north to south collaboration and south-south collaboration. So the overarching goal is to really strengthen pre-service training institutions across Africa to produce the next generation of healthcare workers that can deliver high-quality team-based HIV care. And we used HIV as an entry, but it can be scaled up to other diseases. So we began off with the curriculum development, and of course, after the proposal submission, then we started with the project implementation and training of trainers. And then we are doing it face-to-face, and then COVID happened. And so we had to change strategy and change most of the training online. And we are continuing with the training and the assessment of the work. So we had an expert panel from AfriHealth and UCSF, which I was privileged to chair. And we came up with the 17 modules on HIV content, case-based format, using a case-based format, and with emphasis on enhancing interprofessional collaboration and quality improvement. And the modules were optimized for 2-day workshops, but one could adapt them according to their needs and preferences for each setting. For example, there were 5 modules that were compulsory, but the others, one could choose which ones to use according to their preference. So why did we do this? There's a variability in the quality of care. And also we find that there's lack of support for trainees transitioning from health professions, education institutions into clinical settings. And most times this is a difficult time. Many of you may have gone through this, and this transition is not easy, and trainees really need support. So we thought that was a good entry point for us to support them. And also there's suboptimal interprofessional training opportunities. We are required to work in a team when we get into the clinical setting, but in most cases we are trained in silos, and we don't get an opportunity to train together. So we thought this was a good way of doing this. And so we thought this potential solution was to expand and enhance interprofessional models of HIV education through development of training packages and through collaboration with the AfriHealth partners. So far we've had 145 partner training institutions that are participating from the different countries, as you can see on the map, mainly in the East, Central, and Southern region, but also some from West Africa. And we have over 100 clinical sites that are affiliated sites, affiliated to these 145 partner institutions in 14 countries. And to date, we've trained over 13,000 learners and over 1,300 facilitators through 45 training of trainers workshops, and we've had 125 interprofessional education workshops and about 18 webinars. So a lot of work has gone into this. And just to give you a little insight into the impact, we've had we've done some qualitative evaluation, and we've noted improvement in HIV knowledge, and one medical student from South Africa thought that the course was excellently structured and that it forced the different sectors to work together and solve issues, and also exposed various knowledge gaps within those sectors. There was also improvement in learner confidence, with one laboratory student from Botswana indicating that he had his confidence to work in a team had really been impacted by this treatment, by this training, And there's greater awareness of the need for interprofessional collaboration among the trainees. We also came up with a learning management system for AfriHealth, where all these courses are shared and they are easily accessible. And we are putting other courses on this learning management system, and we are using it to reach many countries within the region. There are, of course, some challenges. We have administrative and financial challenges across the region. It's not easy to transfer money and also to administer large projects across the region and also across continents. And also, how do you assure quality across so many institutions? And finding that institutions are at different levels. Some had been exposed to interprofessional education, others were just at the beginning. They had never done in interprofessional education, and some had done case-based training, but others had never used that approach at all. But also the challenge of how do you translate this into curricula in the different institutions? In most institutions, we have not yet been able to do this. The training goes on in the different sites, but within the streamlined curricula, this has not happened. And still this is happening in education, but how do you transform it into practice that people can actually work together as a team and improve patient outcomes? And also the issue of sustaining the program beyond the funding is also another challenge. But we've also realized many lessons we've learned from this program. There's a great leadership potential within our region. There was also expansive pragmatic capacity. There was lots of interest, and so many institutions signed on to this program. And it was exciting to see that we could reach so many institutions and so many individuals with this program. And there was also tremendous excitement around interprofessional education and quality improvement. And we learned that partnership is a key to success. Seeing how many institutions were working together, this led to the success of the program. And also, because this money came in through HASA, there was a tremendous momentum and enthusiasm to ensure the implementation support of PEPFAR targets. And we are still sustaining what was done in NEPI and MEPI, which is one of the aims of formation of AfriHealth. And we've learned that capacity building is a continuous journey. We've had some publications, and they are available for you to look at. Just a few of those examples, they are available for you to see. So the take-home message is that networks of communities of practice can impact quality improvement, and there is potential for rapid cross-country dissemination of evidence-informed practice by forming partnerships. You can see how many schools and countries and individuals were involved in this program. And we believe that in this African proverb that if you want to go fast, you go alone. If you want to go far, go together. And our past president, Professor Mariki de Villiers, added on leaving no one behind. So we are working together to ensure that AfriHealth impacts health outcomes in our region. Sorry, just to say, to thank PEPFAR and of course UCSF and HASA for working with AfriHealth on this program. And just to invite you to our AfriHealth Symposium, which will be happening the first week of August in Maputo, Mozambique. I'll put the link in the chat so that you can have a look at it. Thank you very much. Over to you, Nancy.
Well, Elsie, thank you so much for sharing that. That was really just a phenomenal presentation. I really was just blown away by not only the number of partners that were involved in the educational program, but just the impact and the number of participants and the learning management interface. It just hats off to you and to the team at AfriHealth for this incredible initiative. So I think, are there any questions for Dr. Kiguli Malwadi or comments as we continue on the session?
Keith.
Yes, Keith.
Thank you, Nancy. Thank you, Matthew. I just wanted to just, on behalf of all of us at CUGH, really thank Dr. Kiguli Malwadi for her incredible, enduring partnership with CUGH and leadership that she has shown all of us. And I also want to just draw attention to Mrs. Georgina Yaboa, who is Executive Director of CUGH and who is really a wonderful partner for us. And we really thank Mrs. Yaboa for being here and all of her support that she gives. And finally, I just want to draw attention to, and maybe Dr. Kiguli Malwadi would just describe this a little bit. She is a leader at the African Center for Global Health and Social Transformation. And I want to just draw attention to this book that her colleague, Dr. Francis Amaswa, wrote. But I know Dr. Kiguli Malwadi and I know Mrs. Yaboa had asked a question in a previous session about the importance of strengthening ministerial capacity and governance capacity. And I wonder if Elsie, you could just share with us your views on how this is so important to be able to scale up the programs necessary that countries want to do and people want to have. Thanks again, Elsie. We really appreciate it.
Okay, thank you very much. I think strong ministries for strong health systems, that's the title of that book. And this is very important, especially in our region. And as Jim Campbell was talking about leadership, I think leadership is key for success for anything. And we could, as health workers, we could do our work, but if there's no leadership, especially at the political level, then we are not likely to get out of these problems, that the challenges that are facing the health workers. And I'm going to actually talk about that at one of the plenaries that Keith invited me to at the CUGH about leadership for health ministers, because there's a large turnover of health ministers in many of the African countries, and also actually of other ministries that collaborate with the Ministry of Health. And in that kind of environment, we need strong leaders that understand what health is all about. But in many cases, most of these, the ministers are actually not in health. And even when we get those from health, they are usually clinicians and focus on disease rather than promoting public health. So it's important from that work, a handbook was produced, which is a handbook for ministers to tell them about the health system, about how to collaborate with within the whole environment of health, knowing that it is an intersectoral, it has an intersectoral aspect. It's not just about leading the Ministry of Health, and how to collaborate with the technical leaders within their ministries. So I'll talk more about it at that plenary, but leadership is key in every aspect of work, not only in health, but leadership and governance being one of the building blocks for the health system is one of those that is actually neglected, especially in our region. There's a lot of focus on service delivery and medicines, and then we forget about the leadership and governance. Thank you very much.
You know, that's really excellent. And I don't think it's just on the African continent where that's an issue. And I think that's a wonderful approach to be thinking about leadership at that level, or the preparation. That's really excellent. And I'm seeing many comments here about how inspirational your talk was. And it's really another very ambitious initiative and cross countries, and really, really excellent work. I do sit here thinking, I think the sustainability is a challenge with financial support to keep this going, I suspect. Do you have ideas for that?
Oh, yes, it's a challenge, but what we would really like to see is to integrate this work into curricula in the different schools that are participating. But we know that curricular development and curricular change takes time. So we are working on that, because if it's integrated into the formal curricula, then it takes root. And this can be scaled up, not only for HIV. We used HIV as an entry point, but for other issues like with COVID-19, when COVID-19 came on, we got some more modules on COVID-19 and added them, but also other non-communicable diseases, we can use this type of approach and make sure that this team-based care is emphasized, and quality improvement as well. Thank you.
Thank you so much. Guess we will move on now to Dr. Keith Martin, who many of you know is the executive director of the Consortium of Universities for Global Health, and he was the inaugural person in this role and has been in it since 2012. And before that, Dr. Martin served as a member of Parliament in Canada's House of Commons, and he held portfolios in foreign affairs, health, the environment, defense, and international development. So very pleased to hear your comments and what you've learned.
Thank you very much, Dr. Reynolds and Dr. Dasko. And first, a big thanks to both of you. For everybody who's on right now, Dr. Reynolds and Dr. Dasko have really done an extraordinary job with the members of the team, which you'll get to know in a little bit, because we've created some products that we hope will address this pervasive challenge that you've heard about today. But I just wanted to, from all of us here, give a big thanks to Nancy and Matthew. Everybody's a volunteer on our committees, and really they've done an amazing job. So I just wanted to talk a little bit about what we've heard today, and talk a little bit about the what to do that connects Jim, James, and Elsie's comments, if I may, and then receive a lot of questions from all of you about what we're talking about. And I think, you know, if we think about it for a second, about if you put yourself in the hands, and many of us are clinicians, about if you were a surgeon, for example, in a low resource setting, what do you need, right? You can be the best surgeon in the world, but unless you have excellent nurses, water, power, supply chain, management, meds, the material, all of that and more, and the ecosystem of other skill sets necessary, you won't be able to treat the people that come by your way. So I think if we look at human resources, I look at it as an ecosystem of skill sets that Dr. Kuguli Malwadi referenced. And it's not only those of us who have the clinical skills, but it's that other half that are necessary that require the management and administrative infrastructure necessary to have all that stuff that we need to be able to work from prevention to treatment to management of the issues that feed not only into health, but into the social determinants of health. Because if we really look at the big bang for the buck, how we're going to improve people's well-being, achieve the sustainable development goals that Jim mentioned initially, we're really looking at addressing the social determinants of health that gird and underpin as the foundation of improving human well-being. And structurally, it is, as is heard from our three speakers today, it's an all-of-government approach. And this book I referenced before, it's a short little book for ministers of health, but as Elsie mentioned, it really refers to the need to strengthen ministerial capacity. But for a short little story, I was in West Africa when I was a member of parliament, and I was visiting as part of a delegation, and one of our colleagues, a member of parliament in a West African country that will remain unnamed, she took me to her office and she said, "Keith, how can I do my work as a member of parliament with this desk and a lamp and a very modest amount of resources?" And no one can. So we need to look at that strengthening. So then the question is, how do we do that? We look at trainers, and then who are the best trainers? Well, it's not necessarily the high-income country trainers. Creating platforms like what's happened at AfroHealth that can connect trainers, particularly in the region, that are where there's a cultural understanding of where they're operating, where they understand the language, where they understand the clinical environment, where what they're doing to build is relevant to the infrastructure that they have, I think is critically important. And at CUGH, which you'll hear from Dr. Dykins later on, we've created a platform that we hope will be able to strengthen those skill sets and align the right trainers that are needed by the institutions and the right curricula, which is also, of course, important. The other thing is that funders need to change, right? Action follows money. And if there are any funders on this call, they need to really listen to what all of our speakers are saying today, because they have the power to reform change, not only what is being done in terms of education and research at an academic level, but how not only the academic sector, but other sectors are actually behaving and operating. And that the investments, as happened through MEPI-NEPI, as Elsie mentioned, those funds went through those African institutions. They need to go into those African institutions so that those institutions can manage them and they can determine who they're going to partner, partner with. I think that from our perspective, CUGH, what we bring to the table, and we invite anybody who's on this call to please join us, because we certainly need help in this effort with people like the team at AfroHealth, but also members on this call who are doing great work, like Dr. Kamholtz, who's doing fantastic work in strengthening nurse training in Nepal, to Dr. Anuru Bahari, who's working with Sierra Leone to address their mental health care capacity building. So we want to work with you to do this. And so please look at us as a partnership to be able to do that. So what would that look like? Well, there are a few buckets. One is, please use and share the capacity building platform. It's really important. Second, contribute to the curricula that our education committee subcommittee on curricula produces. Third, be able to also look at the advocacy work that we are doing. We need to work together in terms of advocacy to be able to achieve that goal. I will close with one issue, which, the important issue, an important part of this is who's funding it, how is it being funded, right? So we held a session at a previous conference by design on the issue of corruption. And if you look at official development assistance globally, it's about $147 billion a year. If you look at the amount of money that's lost in corruption, according to the IMF, it's about 1.5 trillion, that's trillion with a T, dollars per year. That money's stolen from low-income countries and middle-income countries, but low-income countries particularly. That money is stolen and it doesn't stay there. It comes into high-income countries and is deposited through our financial instruments, legal financial instruments. It's laundered and deposited in assets in our countries. So we, high-income countries, need to stop being part of the problem, stop allowing money to be stolen from high-income, low-income countries, return those resources that are deposited in our countries and get them back to those countries so it can be used for the public goods that the citizens of those countries want. That's our responsibility. So in our conference, as Dr. Kuguli Malawadi mentioned, we're going to have a session on governance issues, and we're going to talk about how systems can be strengthened, not only ministries of health, but ministries of finance and public works and justice, because we know if we don't have the judicial underpinnings and legal underpinnings to enforce laws to protect people, bad things happen to people, and we're seeing that all over the world. So I think finally, just to say that when we're talking about health, we are talking about that ecosystem of social determinants of health. It's important when we're advocating to know that health does not have the power at the cabinet table. It's the money, which means finance. So you have to engage the finance ministers, and we have to put forward, build relationships with governments, strengthen their public health system, their public service, not only the elected, but importantly, the unelected public servants that do the bulk of the work in actually delivering public programs. If we're able to strengthen that ecosystem across all of government, then countries will be able to have the foundation of development that is being neglected for far too long, and will deliver the public programs that will improve and address the social determinants of health and the sustainable development goals. Thank you, Dr. Reynolds. Back to you and Dr. Dasco.
All right, Keith. Thank you so much. Really, really great synopsis there, and I think a great kind of way to take us into the brief pause. Are there any questions for Dr. Martin before we go to the break?
I see a comment here in the chat box about virtual training has so much potential, but there does not seem to be funding to improve the power grid and internet access for healthcare systems in low-income countries.
Yeah, that's a great question. Thank you so much. So this is the digital divide. And it is remarkable as we talk about access to and producing online tools. But if you look at the digital divide, it is massive. So if any of you have or know of any organizations, groups, particularly the private sector, because this is a private sector issue, of who is actually doing really good work to be able to bridge that digital divide, not only software and hardware, but also the IT infrastructure that is necessary so that colleagues in low resource settings can have the bandwidth, 3G plus, to be able to access the tools, communicate with each other, and actually operate to improve the well-being of the people they need. The World Bank, by the way, has done some good work on this area. They did a pretty good report on it, but it's going to require all of us, I think, at a country level to be able to advocate for those areas and identify the private sector IT companies that have the power and the know-how to be able to bridge this gap. We'd love to be able to work with you in that. Thanks so much for your question.
Keith, can you there's a question in the chat from Jude Adam about the the book that you're showing, can you put that in the chat, like the title and the author of the book?
Yep.
There's some
I'll do it here. Sorry. It's the Handbook for Ministers of Health. Dr. Omaswa and Dr. Joavi Buford helped to write it. HS, I don't know, Elsie, did you want to say anything regarding this?
Yeah,
There's also another great
yes.
one on African health. Did you want to say something, Elsie? Sorry, you please.
Yes, you can find it. I'm going to put the website. The one on African leaders can be found on Amazon as well.
Yeah, that's this book that Dr. Kuguli.
Yes, African Health Leaders. That one is on Amazon. It was edited by Professor Omaswa Francis, who is who has been the executive director of our organization. Strong Ministries for Strong Health Systems is available on our website, and I'm going to post the website in the chat box.
Fantastic. And Angela Chang put something in the chat that I think is really, very, very poignant and well stated, which is that, comments and applauds your points, Keith, but says, also that high income countries need to reconsider and self-reflect on what global health means when it's being done from a position of distance and privilege, and consider what reciprocal exchange means when partnering with low and low middle income countries. Like twinning is actually sharing of funding and not just research and data. It's about shared governance, about shifting some of that privilege to the partnership.
Yeah, no, absolutely. And we can share, well, actually, I'll try to find out. We did an article with Dr. Binawaho and a number of folks on exactly that point, with a number of recommendations, which is on our website at CUGH.org. Folks are definitely, it has a number of recommendations to that point, Matthew. And if I do a shameless plug for our conference next week, if you're in DC, please come to our in-person satellite sessions on the 13th. They're all free at CUGH2023.org, and also our conference from the 14th to 16th, where many of the folks here are going to be there, and you can have a chance to meet with them and listen to some of the presentations they're going to make. So CUGH2023.org. Thank you, Matthew, for allowing me to take that shameless plug.
Yeah, sure. And there's one other comment here, Matt. I don't know if you want to share that.
Oh yeah, it's from Veronica Nijakar, who says she also likes the idea to stop leaders from low middle income countries from investing in high income countries and deny healthcare abroad, so they could actually focus on developing healthcare systems in their own countries. So it's a demand or a supply side approach. So appreciate that comment, Veronica. That's awesome. So Nancy, I think we can probably go into a short pause, maybe 10 minutes. Is that kind of what you're thinking?
Yeah, maybe come back at 3 o'clock.
Yep, 3 o'clock.
And I want to thank again all our speakers from this panel. It was really very interesting. And
can I wanted to give, so after breaks we have a tendency to sort of break and then hey, that's enough. So I actually, since it's a workshop, I wanted to see if we could just ask for a bit of reflection during the 10-minute break, and for folks, since this is a capacity strengthening workshop, everybody here has some degree of experience. You're here because you're interested in hearing from others, but perhaps over the break, if you can write in the chat or take notes if you don't feel comfortable sharing in the chat, and be prepared for discussion later when you think about programs that you've worked in or that you've heard about that are focused on capacity strengthening, collaborations between different institutions, either South-South or North-South, bidirectional or not. What are some, if you can give either an example of a successful initiative, an initiative that was not so successful, and then or a best practice that you would want to share with the group. So I think if you can think of one of those three, or if you want to address all of them, just be thinking about those over the break. And then when you come back, just as we're hearing from speakers, feel free to put them in the chat, and we will, when we have time for discussion later on, hopefully we can get to some of them. Is that okay, Nancy?
Yep, that sounds great. All right, we'll
All
see
right.
you all back here, top of the hour. Thank you. Well, are we ready to carry on? I think we'll go ahead with the presentations from our speakers for the next section and hold some of those thoughts that people might have had over break for part of our discussion at the end. So now we're going to move into discuss some of the examples of work that members of the CUGH workforce are doing. And our first speaker is Andrew Dykins, who's an associate professor of family medicine at the University of Illinois at Chicago and director of global health systems at the UIC Center for Global Health. And he is going to share with us the CUGH capacity building database project that he has led and that Keith Martin has referenced a couple of times here. So Andrew, are you there? Yes, so please, the floor is yours.
Greetings, thank you. Okay, very good. Well, thank you so much for the opportunity to be with you today. This is certainly an honor. And many congratulations to all of those who have presented thus far in this very informative and insightful special session. So I'd like to share with you today, discuss, sorry, I've got some things in my way here. I'm trying to clear out my screen. There we go. I'd like to discuss with you today about the CUGH capacity strengthening platform. And this is an initiative that we've been working on for several years, very closely from the very beginning with Dr. Kuguli-Mawadi through CUGH and many, many others. And this is a global matchmaking web platform facilitating equitable institutional partnerships and mentorship to strengthen health workforce training capacity. So I would encourage you to engage with this platform. And you can do so by scanning the bar that you'll see throughout the presentation. I'll also provide you the web address, which is cughcapacitybuilding.org. And so I'll just very briefly introduce some of the considerations as to why this initiative has been developed. But much of this has already been talked about and touched upon today in the very informative presentation, so I won't spend too much time on that. But this is a short list of some of the most influential team members that have provided a lot of guidance to this project over the past several years. And the funding that has supported the development of this initiative began in 2017 with the Tom Hall Education Subcommittee Small Global Health Education Grant, and was subsequently funded in 2022 by the U.S. Civilian Research and Development Foundation. So we are very grateful for the funding that has provided the development of this initiative. And just as a side note as well, we are continuing to look for additional funding to further develop this platform, strengthen it in future phases. And so please let us know if you have particular thoughts on something of that sort. And so healthcare workforce has been mentioned, of course, in detail, is very important for equitable access to healthcare services, to pursue universal health coverage, and in pursuit of the sustainable development goals. Of course, it has been mentioned that there's a considerable shortage of global health workers, and this particularly affects certain regions, as very much highlighted in previous presentations. We would like to emphasize that partnerships, training programs, and mentorship are modalities that can be useful in helping to address the workforce shortage in terms of developing training capacity. And so individuals and institutions can connect and share training resources in order to strengthen clinical and research capacity in low resource settings. So this addresses the challenges of a lack of qualified trainers and mentors in some contexts, as well as the challenge of connecting existing expertise and established training programs to areas and individuals with identified training capacity gaps. And with that, then I'll go into just providing an overview of the CUGH capacity strengthening platform and really emphasizing the details on how you might be able to engage with this platform. And so let's take a look. This particularly, there are certain steps that you can go through to engage in various ways, and it requires initial registration on the site, which again has been mentioned at cughcapacitybuilding.org. It also can be found on the home screen or on the webpage of CUGH. Once you have registered for the site, you can create postings, in particular in three separate areas in search of partnerships, which you would post your training needs or expertise. If you have an established enrollment-based training, you can also post that. Or if you're seeking a mentoring opportunity as a mentee or a mentor, you can also post that. You are also able to search the database, the platform, to identify new partners for potential partnerships, training programs through which you would like to potentially enroll to increase your own capacity among various areas, and in order to find mentors and mentees. The platform allows you to connect with the individuals who have created those postings, share information if you choose to advance potential partnerships, connect with programs, or connect to individuals or institutions. And then, of course, we can all strengthen capacity together through this initiative. So let's take a look at each of these in turn. So in order to register for the site, then you'll just need to go to the web URL and click the sign up button. And that will take you through a series of questions that are relatively brief that just allows you to get some basic information up on the site. That will create a profile page for you that you can then, after you've registered initially, add additional information such as some photos. And then you can edit your profile and provide more detail about your institution and other considerations. So please do that so that others will know more about you. After you've created your profile and register on the site, then of course you are welcome to create postings. You do this on the left by clicking on dashboard, and then you can click on create posting. This will take you to a series of questions based on what type of posting you want to create. You may see additional questions pop up. Please create a posting title that is informative. If someone sees what you're posting, that they would readily understand what you are seeking or searching for. And then you are able to respond to a series of questions to help categorize this posting, and then you can provide some additional information. You can categorize your posting among several different areas, one of which is partnership, in which case you would select either it's being a general posting or an implementation science posting. And these are two broad categories that we have currently developed for this site. Note that general postings that are of an implementation science nature will also show up under searches for the implementation science. So these databases are connected, but there are different ways of kind of focusing the conversation. In addition, you can categorize your posting as whether or not you're seeking a training program, seeking a mentoring relationship, or a partnership for capacity building. And then you can stipulate whether or not you're seeking training expertise, or if you're providing training expertise or offering the providing of a training expertise. This would be an example of perhaps something that might be posted with selected categorizations, and then an opportunity to just provide a bit more additional information about that particular type of posting. A very straightforward manner for partnership engagement. If you are posting an available training program, then you would follow by posting what type of training program you are creating, and that you are creating a training program by clicking on the Seeking Training Program, and then where that is taking place. And then you will be provided the opportunity to provide some context about that particular training program. There's a series of questions here. Please provide responses to as many as you feel would be necessary for the person seeking more information to fully understand the scope of your training program. You are also able to provide a brief description and additional information, as well as a URL if relevant, for that particular program. If you are wanting to post something relative to mentorship, then you can select Seeking Mentoring, and then stipulate whether or not you are a mentor, a potential mentor, or a potential mentee with additional information. So irrespective of whether or not you have created a posting, you are also able to search the existing postings. And so you can do this by clicking on Search Postings on the left sidebar, or search general postings, or specifically search implementation science postings. And so that gives you a window into each of those particular categories. This is what the search page looks like for postings. Many of the more recent postings will pop up on the right, and the left is a series of filters. The first filter is just keywords, so you can just search open keywords across all of the existing postings. In which case it would look something like this. If you were to search cervical cancer, then the postings that mention cervical cancer would populate. You could also filter without keywords, or you could filter with keywords, but by selecting the filters on the left here. So if you're looking for implementation science training programs, then you would filter by those. And then you can see that certain training programs have popped up automatically on the right side of the screen. You can then engage with those particular postings by clicking on the title itself, which would take you to an informational page, which is all of the information that has been provided on the website, including the contextual pieces off to the right, and the detailed information in narrative form on the center part of the screen. In addition, at the bottom, there is information on the person who has posted that, the contact person. So you can request to connect by clicking on that button, or you can save this posting to your own personal list of interest to you. So if you connect, then it will stipulate that there is a request that has been sent to this person. And if you have saved, the heart will be filled, and this will be, you'll be able to find this posting again in your saved section, which I'll share with you in just a few minutes. Once you have connected with an individual, you can go to their own individual profile page, and on the timeline, you can share, you can reach out to them directly. So you would click on timeline, and then you can write something to that individual by clicking on this section right here. And I'll share with you a bit more information about how to do that in just a minute. This is where saved postings can be found on the left sidebar. You can click on that, and that takes you to your personal saved postings, and you can unsave them at any point. But it's a great way to come back and look at things and save them and think about them more in depth as you're kind of having these conversations. All right, so once you have identified potential postings or individuals on the site with whom you would like to engage, you can connect to individuals in institutions, to the training program, contact individuals, or individuals who might be interested in mentorship. By clicking on the left sidebar connections button, you can identify the individuals with whom you have connected previously. They're listed down below in My Connections, and those who have reached out to you with requests. If you click on your own timeline, then you can share information with the wider audience. If you click on that, you will have the choice to share information publicly, or to all members of those registrants on the site itself, or to your own individual connections on the site, or just to an individual that you may reach out to and yourself. So this would be a private message here, this last choice. Then you can post that. And then on your own or others' posts, you can like or comment on those posts just as a way of continuing the conversation. If you have received a notification or someone has directed a message to you specifically, you can find that in the upper right-hand corner of the screen. The little bell will stipulate messages that you have pending. And so if you're reaching out to an individual and you want to communicate directly with that person other than the entire broad audience of the individuals registered on the platform, then you can go to that individual's profile page, click on timeline, and write something to the individual. Make sure that you select only me, which means that this is a private communication with that individual, and then you can post that, and then you can carry on a conversation with that individual. As you develop and share information, ask questions, your private email will not be shared with an individual, so you can conduct this conversation within the site itself. If at some point you want to advance the conversation and further develop a partnership, then you may choose to share your individual contact information, such as email address or phone number, with a person on the site, and you can do that through this direct communication in this way. And then you can take the conversation offline to advance the work of your partnership or mentorship. And then, of course, we will all continue to work together to strengthen capacity. So you can find your saved postings on the left and continue to find ways of engaging with them over time and continue the conversation with the wider audience in your messages section, also on the left sidebar. So you can see all the conversations that you have ongoing and continue to advance those. Please reach out to us at any time with any questions that you may have at the top of the screen through the contact button. And you can ask questions or share feedback for us as we are continuing to refine the platform itself. We are always welcome to feedback that you have. So we're very hopeful that this platform addresses certain partnership principles, such as equitable matchmaking. Whereas a lot of times partnerships are created through in an ad hoc manner by just reaching out via email, finding someone's name online, or connecting with them at a conference, let's say. Engaging through a platform such as this helps you identify potential partners that may have existing needs or resources that may very well match your own. And so it creates an equitable system where there's transparent listing of training capacity priorities that allows individuals in low resource settings to list perhaps those individuals without those priorities within a developing relationship being driven, let's say, by a grant priority. It creates the opportunity for a strong contextual understanding between the partners, being able to share these contextual pieces, and hopefully facilitates equity, reciprocity, bidirectionality, social justice, and humility within the developing partnerships. Also emphasizes a local prioritization to drive external focus, responsibly distributes partnership benefits, and encourages the partnership of organizations, institutions locally. So we're very much hopeful that this platform will advance more south to south, so to speak, partnerships, because it will allow organizations in relatively close geographic areas to identify where their resources and capacity needs might overlap. And hopefully facilitates long-term partnerships through ongoing conversations, which creates more effectiveness and efficiency in partnerships. So please join us at CUGHcapacitybuilding.org or scan the QR code as listed here. These are some of the references for some of the information that was provided in today's presentation. So thank you so very much. I'm grateful for your attention and the opportunity to present and be with you today. Happy to take any questions. Thank you.
Wow, Andrew, thanks so much for sharing those, for sharing the site. It's really quite an incredible feat. It's come a long way. I remember when you beta tested it, and you guys have just been doing an incredible job putting it together. So hats off to the team who's been working with you to do that. Really, really great. And I hope it does create those kind of opportunities to create connections. Any thoughts or questions for Andrew?
Okay, well, people can put them in the chat, and we may have a little more time at the end to if questions come up, and we'll move along here. Our next speakers are Dr. Barbara Kamholtz and her colleague Suraj Bhattarai, who are working on, oh, and I should say that Dr. Kamholtz is a clinical professor in the Department of Psychiatry at UCSF, and she has expertise in geriatric psychiatry. And I believe that Suraj is not able to join us today because of the time difference, but I'm sure she will speak well for both of them, and just get a little bit of an overview about a project that they are leading in Nepal to build capacity in geriatric care, which has been identified as having an important gap there. So Dr. Kamholtz, are you with us? Oh, yeah.
Sorry. Yep, had to click on. So thanks, Nancy. Hi, everyone. Thank you for your participation in this satellite session. And Andrew, that is a phenomenal program. I feel so privileged to be presenting now in the context of all the other extensive effort and expertise too that's been presented so far today. So this project's goal is to develop increased geriatric capacity among nurses working in community settings affiliated with Kathmandu University in Nepal, specifically Dhulikhel Hospital. Nepal, like other low and middle income countries, is seeing a remarkable surge in the numbers and lifespan of its population over 60. This is partly due to the increased availability of healthcare and decreasing birth rates. Actually, within the next 25 years, the population curve will basically invert, with far fewer younger persons available to sustain the economy and health of the population as a whole. And this is true, again, of virtually all low and middle income countries, this population change. But low and middle income countries have almost no geriatric expertise at all to address this. So I'm a geriatric psychiatrist with fairly extensive experience in our military retirement system, working with very frail veterans who have complex needs. So I visited Kathmandu University in 2019 in hopes of offering some help. Actually, I'd gotten in contact with some physicians at KU in the context of CUGH's conference that year, which shows that it's very good for networking. While I was there, I was approached by the head of nursing asking for curriculum updates in geriatrics. So of course, the pandemic slowed our efforts shortly thereafter, although in the fall of 2021, WHO Nepal supported a national geriatric conference to alert the health system in Nepal to the rising urgency of training in geriatric specialty care. And this went over very well. It was strongly welcomed by the 200 people in Nepal who attended in person or virtually, as well as Nepal's Ministry of Health and Population, who actually asked toward the end of the, right before we put on the program, to have some slots for speaking. So I think they understood that this was a really important effort. So in this context, I made a suggestion that the Workforce and Capacity Building Subcommittee of CUGH make an offer of mentorship in geriatrics for nurses as soon as we could get back on the ground. And miraculously, soon after, WHO Nepal made a very generous offer of funding to support this training. So that the focus has been on nursing training is easily explained. Nurses in Nepal, as in many low and middle income countries, are often the sole caregivers in broad swaths of rural and remote areas of their countries. And Nepal is probably the most rugged and mountainous country in the world. So these nurses in Nepal have to be very independent. They will need to have significant expertise to determine in these settings the best ways to support preventive work for non-communicable diseases, which are also rising rapidly in low and middle income countries, and to help caregivers managing the increasing rates of dementia. Nepal will also be dependent on them to identify emergent cases that will need the very specific care of the vanishingly small geriatric expertise within the country. At this time, there's only one geriatric psychiatrist, not me. I visit, but there's fortunately one Nepali geriatric psychiatrist, 5 geriatricians, and 1 PhD geriatric nurse, compared to a population of 28 million. Geriatric expertise in physical therapy, nutrition, occupational therapy, pharmacy, and dentistry, among all the other vital geriatric specialties, is almost non-existent. So ways to dole out this expertise on a national level will also be a challenge. So since that time, 5 of us from the Workforce Capacity Building Subcommittee have been focused on the development of this nursing education program. Suraj Bhattarai, as Nancy mentioned, he's an infectious disease fellow located in Nepal and has made some crucial connections in regard to the development of the program. Of course, you, Nancy, you're also in this group. Andrew, we're very fortunate to have also, who's organized with Archana Shrestha, another public health specialist from Kathmandu University, an implementation study of this project. So we are well set. Over the last year and a half, the program, though, has had to work its way through the choice of credentialing by the Nursing and Social Security Division of the Ministry of Health and Information in Nepal before we could really get started versus credentialing by Kathmandu University itself. It's been kind of complicated. But within the last few weeks, Kathmandu University has decided that the format will be a 6-month fellowship in geriatric nursing. And in that light, as the principal geriatrics content resource, I've been able to obtain some substantial commitments to do in-person and Zoom didactics, as well as direct clinical supervision, which I think is really critical. These nurses need to know exactly what they're looking at. It can often be vague and confusing, especially when there's cognitive impairment involved. And much of this comes from India, which is an ideal partner given the cultural similarity. So we're fortunate to have these resources. So at this time, the 6-month curriculum is set to begin in September this year. So we've begun an active effort to update the existing geriatrics curriculum within nursing at KU and to supply international experts to deliver their expertise. And that's where the program is at this point. And I'm very grateful to have the support of the committee, who luckily grabbed on immediately to the need for geriatric care. And it's just been a delight to work with CUGH in general. So thank you for your attention.
Thank you, Barbara. Really, really wonderful work that you're doing there with Suraj in Nepal. Thank you for giving us that perspective. It really is sort of a, you know, it was something that was initiated by your partners, and you're really trying to mobilize resources to strengthen the care for that very in need population. So thanks for sharing that.
Sure. Yeah, it's a really great example too of, government, WHO, university partnering to fulfill this need. So, and I thank you for all your persistence in pulling all these entities together. So, yeah, it's great to see it moving. So,
this is one of the messages is it does take persistence and patience, and it can take a long time to move. It's like a huge change in an institutional focus. So it will require time for such programs.
Wonderful. Well, if you have questions or comments or thoughts, please drop them in the chat, and we'll hopefully have some time after the last presentation for some more discussion.
Okay, thank you.
So our last speaker today is Dr. Veronica Nikar, who's an associate professor at the University of Maryland School of Nursing, and she will be discussing her very interesting work of building capacity in bioethics, expertise and leadership in Gambia. So, floor is yours.
Thank you, Nancy, and great work, Barbara, in Nepal. I'm sure we'll be able to use it in Gambia as well. So it seems like I am between some of you folks, between you and Dina for some of you folks. My presentation I'll be talking about the GAMRETI program, which is building capacity in bioethics expertise in leadership in the Gambia. And I am grateful to be part of this team presenting among seasoned scholars who have worked for decades in this space. So thank you for this opportunity. As you can see on the right of my screen, these are our collaborating institutions: the University of the Gambia, the Medical Research Council, Gambia Unit, and the University of Maryland, Baltimore. And we are grateful for funding support from the Fogarty International Center of the National Institutes of Health. And this particular session, the satellite session, is co-sponsored by the Office of Global Health in the School of Nursing at the University of Maryland. And special thanks to Eli Snyder, who's the director of the Office of Global Health there. So the presentation objectives, I'll be discussing asset-based strategies in the development of a bioethics certificate program in the Gambia, and also identify lessons learned and next steps. So to put it into context, Gambia is one of the smallest countries in Africa, but is the smallest in mainland Africa, but one of the smallest in Africa, because sometimes people forget that there are islands also that belong to the African continent. So as you can see, it's the most western country in West Africa. And the River Gambia runs through it, as you can see on the lower left of your screen. And about 37 miles on the west opens out into the Atlantic Ocean. And we are now enjoying a budding democratic state and coming from a 22-year autocratic rule. So there are a lot of opportunities in terms of developing the country in a way that is aligns with international standards. So the Gambia has a weak healthcare system with extensive needs for human and resource capacity development, including the development in research, bioethics, and methodology. So just a quick introduction here, and some of these have already been discussed by Dr. Campbell, and to a certain extent, Elsie as well. We know that the Gambia's research needs continue to grow exponentially, and in tandem with development opportunities, the Gambia has seen a rapid increase in the need and interest for research. And in response to the country's growing research needs, the University of the Gambia and other institutions are expanding to respond to those needs. But in spite of the response, in spite of the increase in the number of research studies needed, training in research ethics and methodology are still limited. So in addition to all of that, the rapid increase and complexity of global collaborations, the high burden of existing and emerging health challenges are rampant. And as I've alluded to before, Dr. Campbell has actually addressed this before. So these actually support the urgency to strengthen bioethics capacity and develop the tools, support, and resources needed to address these growing needs in the Gambia. So in response to these important and growing needs, we established the Gambia Research Ethics and Methodology Training Initiative we call GAMRETI. And it is designed to build and develop workforce capacity development through 3 program goals. And these include develop and implement a certificate program for the foundation of a master's program in 3 years, provide opportunities for professional development activities, as well as establish formal mentoring programs. So we utilize the 3 interconnected, interdependent levels of capacity development. And we do think that we were unique in our approach because we wanted to be sure that we captured all the dimensions of capacity development. So for individual capacity, which focuses on individual level capacity, and specifically the development and improvement of health professionals and research scholars' knowledge, skills, and competencies. The individual capacity is the first one. Then we have the organizational capacity that builds and strengthens infrastructure and improves responsive accountability and transparency for sustainability. And I know that that has been discussed as well in terms of making sure that these programs remain sustainable. And the third one is enabling environment capacity. And this level looks at development, focusing on strengthening and reinforcing policies and procedures, with particular focus on the socio-cultural congruence, which would ensure that the activities are efficient and sustainable in terms of the implementation of the program. So we did engage in terms of making sure that we utilize all 3 of these levels of capacity development. We engaged key stakeholders in a summer consultation workshop. We invited ministers, the community leaders, particularly in the rural areas, religious leaders in the communities as well were invited. And in our work, we strategically prioritized developing an enabling environment and organizational capacity to lay the foundation for maximum impact, because we hope that with that approach, it will actually facilitate the implementation of the individual capacity related activities, which will follow in the form of the formal training programs, the professional development activities, as well as the formal mentoring programs that we've planned. So in terms of the implementation strategy, to develop capacity for an enabling environment, our goal was to contextualize the certificate program content for relevance, applicability, and congruence with local realities. So the 2022 Summer Stakeholder Consultation Workshop was an important start, and it helped us to better understand the context within which the research studies were conducted, because we had a good discussion around some questions that we posed to our attendees. Importantly, the socio-cultural context that would inform the implementation and as well as the interpretation of research ethical principles in the Gambia would also support what we're doing to promote positive health outcomes. So we were intentional during the workshop, like I pointed out, and we had a lot of group activities that generated robust discussions around what we do, what we were talking about. So we identified some of the themes from the workshop that informed the development, which is still ongoing, the development of our curriculum. So regarding the development of organizational capacity, similar to other developing countries, as Barbara mentioned, the Gambia has a fragile infrastructure to accommodate the high level of research activity that's needed. So it does, as I mentioned before, it does have a budding research enterprise, and the value added to clinical practice through research continues to be widely recognized and appreciated, and it has actually generated a lot of interest. To this end, there's growing need not only to develop individual capacity, but organizational capacity as well for sustainability. And I liked I haven't seen the books that Elsie and Dr. Keith shared, and I think that would be a good resource as we continue to see how we can ensure that the ministries and other leaders are involved. We have been hard at work supporting the research offices, particularly at the country's largest public university, the University of the Gambia, which is one of our collaborators, to digitalize the grant disbursement processes, because most of the work that they do is paperwork. So it takes a lot of time, it's inefficient, among other things. Additionally, we are working on a manual of operating procedures document, which would guide seamless implementation of the grant-related activities. So all of these are in our efforts to actually make sure that organizational capacity is there. So moving to individual capacity then, we have the opportunity to work with 3 groups of regional and global experts, an advisory board, curriculum committee, and consultants. And these are regional consultants, and I'll share your names towards the end of the presentation. And these folks, they have participated, and they will continue to review program-related documents. For example, when we completed the draft of the certificate curriculum, they reviewed the curriculum in detail and then provided feedback. They would also continue to provide mentorship, select final candidates for the certificate and master's programs, and as well as among other responsibilities. And most of these folks, they're also funded by FOGARI. So during the workshop, as I alluded to before, we did intentionally include group activities interspersed throughout the program. And we had a set of questions, and I give you a couple of them as examples. We asked, what are the social and cultural issues that affect research ethics in the Gambia? What role could community members and leaders have to improve the conduct of research in the Gambia? And we also asked them, for example, to reflect on presentations and share their thoughts about how the presentations that were presented could inform the certificate program. And these were the workshop themes that we identified: the training needs across all levels, mentor and mentoring needs, community engagement in program development. I think our community members that actually attended were really enthused and were quite excited to be part of the program. So they were very liberal, in other words, with their suggestions and contributions. Collaborations, they also wanted, the themes that emerged also included collaborations in research, studies, and publications. And I think this is one way, that's one of the ways that the platform, the CUGH platform, could support some of these mentoring as well as collaborative endeavors. They wanted to establish an institutional review board at each institution, because currently we only have one ethics committee for the entire country. Even though Gambia is a small country, approximately 2.5 million, but still one ethics committee is quite limited, to say the least. And they also talked about the establishment of a national regulatory board, which currently we don't have in the Gambia. So the key lessons that we learned, and I think a couple of them were mentioned by Barbara. We need to engage communities in meaningful ways, understand that work in developing countries takes time. Follow-up messages and reminders are critically important for progress. Because what you find is that, as we talked about the digital divide earlier, we know that their internet connection is not as consistent as it should be. And that's one of the reasons why I'm in a conference room right now for this presentation, because in the hotel room, the connection is quite spotty. So I had to be here so that I make sure that I'm connected throughout. Provide community partners with incentives, and also importantly, to account for costs such as wire transfers and other expenses. And as we talk about funders, I think sometimes in terms of the money that they provide for based on the budget, some of these costs are not taken into consideration. And I think that as we continue to ensure that we do engage all the stakeholders in meaningful ways, that these are taken into considerations and the costs are put into, are also integrated in the budget. So in terms of next steps, we actually held our, that's why I'm here in the Gambia right now, because we held our second annual workshop this week. And part of the process is that during the workshop, we get to do a snapshot selection, if you will, of potential candidates for our program. And they will be shortlisted and invited for an interview. And then after the application process, of course, and then that list will be sent to the advisory board members to actually do the final 6 selection. We only have budget for 6 of the trainees, but then others may decide to self-pay or actually ask their institution to pay for them. And yesterday, which was the last day of our workshop, we actually have the provost of the School of Medicine and Allied Health actually saying that they would sponsor 1 student. So we now have 7. And there was another regional officer that attended from the rural areas, and he is also thinking about having one of their staff also attend our training. So it was the attendance at the workshop quite impressive. Folks were enthusiastic. You can actually see that there's a huge need and people are really willing and ready to really get on in terms of being part of these activities. So following, as I mentioned before, we are still developing the courses for the certificate program. So when we're done with it, we anticipate that that would be completed by the end of the April. And then we will then submit it to the curriculum committee in May. And we anticipate that the certificate program will start in the fall of 2023. So to conclude, our 3-level capacity development approach, integrating community priority needs and developing infrastructures to support program efficiency and sustainability were strategic and intentional in terms of how we think that things might be more sustainable. We anticipate that the GAMRETI program will promote a culture of research in the Gambia and be a model for other institutions. And we also anticipate that graduates from the program will participate in research with integrity and scientific rigor to strengthen the research ecosystem and contribute to the country's development. So a few folks to acknowledge, and this is the list of program investigators and our support staff. And we have Dr. Henry Silverman in the School of Nursing at the UMB. At the University of the Gambia, we have Dr. Jainaba Sisao and Dr. Thomas Sengor. MRCG, we have Dr. F.Y. Youssef. And so for support staff at the UMB, we have Patrick Ballet, and at the UTG, we have Lamin Bayo, who's the grants manager. And actually it's not paid through our grant, but paid through the UTG. But he works solely on our own program to support the grant related activities. And then we have Ms. Tomilayo Felicity Omotosho, who's the program manager at the UTG as well. And I would also like to acknowledge our experts. We have, like I pointed out, we have the 3 groups, the curriculum committee, Mr. Lamin Suare, UTG, Francis Sari, the UTG, Dr. Asanjay at the MRCG, and Dr. Melissa McDermott at the UMB. And consultants, we have regional consultants, and these are, they're all funded by Fogati. At the University of Ibadan, we have Dr. Oduwale and Dr. Jijidi. And then at the University of Ghana, we have Dr. Awa. And for, okay, there we go. And for the advisory board members, we have Dr. Siga Jain, Dr. Mr. Bakari Sane, Dr. Mohamedou Kabir Cham in Gambia, and we have Dr. Lynn Oswald and Dr. Natalie Ram at the UMB. And we were quite intentional because we wanted to have more of our folks working in the program in Gambia and not in the US or in the Western world. So, and I think that's working brilliantly so far. I think that's it. I think this is stalling a little bit. Yeah, and that's all I have. There we go. Thank you all.
Well, thank you, Veronica. That was really a wonderful talk. And, I found it so thoughtful, and to see how you've designed this project. And I love your emphasis, your consideration of capacity development at the different levels. I don't think we often emphasize that in our work. I thought that was wonderful, as well as your lessons learned, which sort of leads into Matt's questions to the group earlier too. I don't know if I haven't been following the chat box, whether we've had any themes coming out there, but
Yeah, no, thanks so much, Nancy. And that was really just a wonderful presentation, Veronica. Thank you for sharing that. I mean, we always, those are those truly horizontal programs, strengthening capacity in bioethics. It's something that sometimes escapes, and it's just really great to see the work that you at UMB are doing with in the Gambia. So really thank you so much for taking the time to present it. Are there
Thank
any
you.
thoughts? Yeah, are there any thoughts or comments for Dr. Njekar?
I wanted to say something, Veronica, thank you so much. I guess I'll turn on my video.
and yeah, please, everyone, feel free to put your videos on now.
Thank you so much, and especially for the community development emphasis. In Nepal, there's the medical literacy is about 25%, which means that in the community, which means that people don't understand what might be a disease such as dementia, or even how to get help for it. So trying to communicate and educate people locally so that they understand the need and will be receptive is critical. It's slightly different than your emphasis, but I certainly look forward to communicating with you about how to really optimize our approaches too. Thank you so much.
Thank you for that comment, Barbara. I appreciate it.
Well, I think we have about just under 10 minutes for discussion. I think there have been a few things shared in the chat about kind of the I think we've heard a lot of presentations today about the just some really outstanding examples, all the way from the WHO and global governance levels, all the way down to initiatives that are taking place between institutions around the world. And it really is, I think, quite inspirational to just see the effort that's being made to try to build these types of partnerships that are going to try to be sustainable, but then also to strengthen capacity to address the health challenges around the world. Are there themes that are emerging? I think just in some of the there's been a couple of resources that have been shared. So Jude shared a couple of really nice resources in the chat. So if folks are interested in, I think, success stories of real successes. And then there were a few. I think the main challenge theme that from the few that posted there was funding. So this is always the challenge in academia. But I think you kind of hear from experiences like what Veronica shared and what others have shared that there are ways to find funding to make these sort of initiatives work. So I really do appreciate everybody sharing those. Nancy, what are your thoughts?
Yeah, I'm struck listening to this by sort of the creativity of some of this work, and definitely the perseverance, and just it's impressive to me how hard everyone who's leading these projects works, and it's wonderful. And I don't know if any of our other participants here have any comments to share. Keith?
I just wanted to thank for all of you. Dr. Reynolds chairs our capacity building subcommittee and has done, Nancy, really an outstanding job of driving that forward. For us at CUGH, this is a deeply consequential impactful efforts. So I would just encourage you to join Dr. Reynolds' efforts. And again, big thanks, Nancy and Matthew, for co-leading this effort, and to everybody here for joining this effort. You've got amazing partners here. Please share the capacity building site that Andrew shared. We just need people to use it across both biomedical and non-biomedical disciplines. But I really just wanted to thank you, Nancy and Matthew, and everybody here for joining this effort, and to the speakers. Thank you.
Yes, absolutely. And I thank everyone for who participated today, and really special thanks to all of our speakers. It's just really impressive, the amount of expertise and thoughtful work that's ongoing. And I know everyone is very, very busy to take time out to share that, and much, much appreciated.
Yeah, I think Elsie's comment in the last comment she made is really, I think, very, very poignant, which is that I think, while we're here in a chat room discussing best practices and discussing these really great examples all the way from the global governance structures down, I think, I've in a lot of ways I've started to think of capacity building as more capacity strengthening, because you only have to look to the around the world to find incredible resources in across partner countries, across LMICs. These are things that are that are already there, and so it really is just creating opportunities and leveraging kind of the privilege, I think, that high income countries have to try to really to bring that to bear on these partnerships. So that's a really great point that you make there, Elsie, that tapping into regional capacity is a best practice in global health, and I think that's the theme that has certainly emerged from here, just hearing from the amazing work that everybody is doing.
Well, wonderful. And I think that's a great note to end on. So again, I thank you all. And we had a question earlier about whether this would be available, and it has been taped, and this will be available on the CUGH website at a later time if anyone is interested in going back to it. So, and it will be widely shared and available to others beyond those who registered for this session. So again, thank you, and good rest of the day, whatever time zone you're in.
Thank you. Bye.
Thank you. Bye.